Welcome to the very important and interesting topic, gastrointestinal pathology. It is a very favorite topic to me, and the lesions of the GIT are so many. It is as long as the list of GI lesions as long as the GIT tract itself. So let us have more interesting aspects in the GI pathology. Mainly it's the salivary gland tumors, especially it is a pleomorphic adenoma, and let us have a look on the various types of salivary gland tumors. Then the esophageal lesions, mainly esophageal carcinoma, squamous cell carcinoma of the esophagus, and the Barrett's esophagus leading to adenocarcinoma. So let us have a look on the various GI pathology lesions. Oral cavity lesions may be ulcerative or sometimes inflammatory lesions. Very common finding is the leukoplakia. Especially it's so common in Indian setup that we keep on seeing the oral cavity leukoplakias. It's mainly because of the habit of eating pan masalas, the gutkhas, and all those tobacco containing variety of addictive substances. So leukoplakia is the white patch in the tongue, whereas erythroplakia is the red patch in the tongue. So erythroplakia is the one which is more precancerous as compared to the leukoplakia. So oral cavity carcinomas, most commonly it is the squamous cell carcinoma, and India is having highest incidence in the world about the oral cavity squamous cell carcinomas. So what is the definition of leukoplakia? It is the white patch which is well defined. Either it could be mucosal patch, or it is usually cannot be removed so easily, or it could be one plaque, small patch or quite big plaque. So you cannot scrape it off. So if it is, you can easily scrape it off, means you should think about candidiasis, which is very common in the in the HIV patients. So we call it as hairy leukoplakias, which are mainly due to the Candida albicans, and even with the Epstein-Barr virus can cause hairy leukoplakias. Then what is seen under microscope in leukoplakia is we see stratified squamous epithelium, which will show thickening. So thick epidermis, it shows hyperkeratosis. Sometimes even it can show coilocytotic change, that is vacuolation in the keratinocytes. And all the dysplastic changes will be limited to the epithelium only. The subepithelium, the basement membrane will be intact. There will be no infiltration of these cells into the subepithelial stroma. That's how we to differentiate leukoplakia from the squamous cell carcinoma, in situ and invasive carcinomas. So most important cause is the tobacco. So tobacco can be achieved in various forms, so that all those things can cause the leukoplakia. Alcohol consumption is very important, and ill-fitting dentures can also be really an important cause of the development of the leukoplakia. So any irritant that causes the continuous irritation to the buccal mucosa, that can cause the leukoplakia. Irritant food also can cause the leukoplakia. We have in India very peculiar habit of the especially the farmers. They will keep the betel nuts, then with the leaves, then they will put a lot of lime in that, and they farm. They will make one good the button like entity. They will keep it in the oral cavity on the side of the angles for a long time. Once they keep, they will not remove it for some 3 hours, 4 hours. So it is containing very high amount of lime as such. So this act continuously irritates the oral cavity mucosa. So along with that, they will add even the tobacco. So the tobacco is the one which is more dangerous. So it can induce the chronic irritation, is the one which makes the epithelium to suffer from the variety of preneoplastic lesions. So remember, leukoplakia is again a preneoplastic lesion, and it's very importantly preneoplastic lesion. It can progress to squamous cell carcinoma in around 3 to 6% of the cases. Remember, erythroplakia is much more pre-malignant, that is having highest malignant transformation, 60%. See, leukoplakia around 3 to 6% of the cases, whereas erythroplakia is much more dangerous in that way. So oral cavity squamous cell carcinomas, very important risk factors are the pre-existing lesions like leukoplakia and the erythroplakia. So any tobacco use, spirit, alcohol, protracted irritation, all those things can cause the squamous cell carcinoma onset. More than that, it is the HPV, human papilloma virus. So we have two groups, low risk group and high risk group. So it's mainly the high risk group So that is the one which is can cause this squamous cell carcinoma. So HPV, remember, it can cause squamous cell carcinoma in variety of areas. Most importantly, it is the uterine cervix, cervical squamous cell carcinomas, anal squamous cell carcinomas in the homosexuals. Again, oral cavity squamous cell carcinomas can be due to again human papillomavirus. So most of the time it is a sexually transmitted disease. So what are the most common sites of squamous cell carcinoma of the oral cavity? So either it can occur over the lower lip, in smokers, floor of the mouth, but most of the time we see it on the lateral borders of the tongue. So most common site of squamous cell carcinoma of the oral cavity, they can ask the question, it is the lateral border of the tongue. So it will commonly spread through the lymphatic route. The oral cavity squamous cell carcinomas will commonly spread through the lymphatic route. It goes to the draining lymph nodes like submental group of lymph nodes, submandibular group of lymph nodes, upper cervical group of lymph nodes. Most of the time, if it is localized, the local resection, sometimes they need to sacrifice the portion of a lip, or plastic surgeon has to do the repair of that particular area, or sometimes the tongue has to be sacrificed, either hemiglossectomy, sometimes even we call it as commando operation, where portion of a mandible will be removed because the tumor will be so infiltrative. Along with that, the K-wiring of jaws will be done, and even the tongue will be sacrificed. So life remains protracted for these patients. So whoever has developed the oral cavity of the squamous cell carcinoma of the oral cavity, so the prognosis is not much good as such. I mean, survival will be good, but morbidity will be more. So they will have to suffer a lot. Let us have a look on the very interesting topic, that is salivary gland tumors as such. Rarely inflammation can also occur. We call it as SIALADENITIS. So it could be due to the viral infections like mumps, which can cause the bilateral enlargement of the parotid gland. Very painful condition, very commonly seen in the pediatric age population if they have not received the MMR vaccine. So sometimes could be due to the bacterial infections. Autoimmune disorders. Remember, one of the important autoimmune disorders is the Sjogren's syndrome. What happens in Sjogren's syndrome? There is autoimmune reaction. Autoreactive T lymphocytes are the one which will infiltrate the salivary glands, infiltrate the lacrimal glands. So this dense inflammatory infiltrating may be so much that there can be even formation of the lymphoid aggregates. So this makes the salivary gland acini and lacrimal gland acini to undergo atrophy. So totally it can result in a dryness, so called as Sika syndrome. So there will be a dryness of oral cavity, dryness of the eyes due to the salivary gland infiltration by the autoreactive T lymphocytes. So rarely Sjogren's syndrome can even progress for the development of the non-Hodgkin's lymphoma. So this polyclonal population of lymphocytes can turn into monoclonal and form the NHL, non-Hodgkin's lymphomas. Xerostomia is again, it is dryness of a mouth, very commonly seen in the Crest syndrome. Crest syndrome is the one which is very commonly asked in the exams. I will tell about it. Then we have one more drying syndrome, that is keratoconjunctivitis sicca. Sicca syndromes again it can belong to Crest syndrome patients. So these are the important autoimmune disorders. Tumors of the salivary gland, surprisingly, very variety of tumors are there. Although they are small in size salivary glands, but so many tumors have been described in the salivary tumors as such, salivary glands as such. So less than 2% of tumors in human beings are salivary gland tumors, and remember 80% of the tumors, around 60 to 80% of the tumors occurs in the parotid gland, and most of the tumors in parotid gland are benign. So 80% of the tumors occurs in parotid gland, 80% of the parotid gland tumors are benign. So that you have to remember. Whereas reverse, so this is actually inversely proportional to the size of the salivary gland. So small salivary glands, minor salivary glands, there only 20% of the tumors occurs, and 80% of those minor salivary gland tumors are malignant. So that you have to remember. Around 10% occurs even in the submandibular gland. Rest of the things occurs in the minor salivary glands and the sublingual gland. So this is what you have to remember. Tumors, the rate of malignancy is inversely proportional to the size of the salivary gland. That's the most important point you have to remember. Around 15 to 30%. On an average, 20% of the parotid gland tumors are malignant, whereas 40% of submandibular gland are malignant, 50% of the minor salivary gland tumors are malignant, and around 70 to 90, average 80% of the sublingual gland tumors are malignant. So remember, minor salivary glands are known for malignant tumors like ribby, cribriform carcinomas, the adenoid cystic carcinomas, mucoepidermal carcinomas are very, very common in the minor salivary glands, whereas pleomorphic adenoma, which is very, very common, benign salivary gland tumor, is very common in the parotid gland. So let us have a look on this important classification of the tumors of the salivary gland. Remember, most common salivary gland tumor is, if they ask us question like that, it is a pleomorphic adenoma. Most common malignant tumor of a salivary gland tumor is, then you have to answer as mucoepidermal carcinoma. So this is the most common malignant, this is most common benign. So pleomorphic adenoma is 50% and 80% of the pleomorphic adenomas occurs in the salivary gland. WARTHIN'S tumor, remember it is a benign, not malignant. It occurs in around 5 to 10% of the salivary gland tumors are WARTHIN tumors. Oncocytomas are rare tumors, 1% of the salivary gland tumors. Others are very, very rare, like basal cell adenomas, duct papillomas. Remember the malignant tumors, they are as such quite rare, but we keep on coming across these malignant tumors as such. So very commonly we come across the mucoepidermal carcinomas, and adenocarcinomas can arise from the salivary glands. It is mainly from the ductal epithelial cells. Actinic cell carcinomas, very, very important and known for recurrence, very aggressive tumor. Actinic cell carcinomas around 5%. Very interesting tumor, I will tell about it. Adenoid cystic carcinoma around 5%. Malignant mixed tumor, again around 3 to 5% of the cases. Very rarely, especially if there is a stone in the ducts, that can cause the squamous cell carcinoma of the salivary gland ducts. Other tumors are very, very rare. So there is one entity you have to remember. Pleomorphic adenoma can turn into malignant. Rarely, then we call it as pleomorphic adenoma X carcinoma, or you can call it as malignant mixed tumor as such. I will tell more about pleomorphic adenoma of the salivary gland. Remember, pleomorphic adenoma is a common word which is used even for soft tissues. There is even pleomorphic adenoma of soft tissue also is there. But what I am telling is the pleomorphic adenoma of the salivary gland. So better word would have been benign mixed tumor, because it is composed of epithelial and mesenchymal differentiation. So there are two types of cells histologically, epithelial component, mesenchymal component, and even myoepithelial component. So that's why it is called as benign mixed tumor. Remember, it's a misnomer actually. Pleomorphic adenoma, you should not confuse it. Whenever we ask in the Viva, usually students will tell why the name pleomorphic adenoma is coined. Is there will be pleomorphism among the cells? They will tell yes. No, there will be no pleomorphism in the cells. There is no pleomorphism of the cells. It is a pleomorphic component. Pleomorphic component, that means variety of components, epithelial component, mesenchymal component, myoepithelial component. So this makes mixture of the various components. Of course, the proportion of epithelial may be more in one tumor, mesenchymal may be more in another tumor. So they varies. 2 cases of pleomorphic adenoma may vary. If I say 10 cases of pleomorphic adenoma, all 10 may show different proportion of epithelial and the mesenchymal components. So the word pleomorphic adenoma is because of the pleomorphic components of a tumor. Don't think it is due to the pleomorphism among the cells. That's a point you have to remember. What is the risk factor? Radiation exposure may be the risk factor, but most time we will not come to know what is the cause for these pleomorphic adenomas. Histogenesis, it is made up of myoepithelial and ductal reserve cells, and they are the one which will give rise to the malignancies, the tumor as such. It is a painless. Most of the time it is a painless, usually unilateral. So pleomorphic adenomas are unilateral, slow growing tumors, they are mobile and discrete masses. So on examination itself, you can make out that it could be a pleomorphic adenoma, but anyway, histological confirmation is mandatory in most of the cases. But remember, it is having an exception to rule of the malignancies. About the rules of carcinomas. So it is a benign, but still is not having well-defined capsule. That's point you have to remember. It is partially encapsulated. The fibrous capsule around the tumor is not complete. It is partially encapsulated tumor. So that's why whenever you excise this tumor, you have to completely excise. If any portion of a pleomorphic adenoma is left at that portion, it is known for regrowth. Again, recurrence is very, very common. So complete enucleation is most important in the pleomorphic adenomas. Although they are benign, they are known for recurrences. That's a point you have to remember. They are known for recurrence in spite of the fact that they are benign. So that makes the treatment of pleomorphic adenoma a little complicated for the surgeon. So he has to take care of that the tumor should be completely excised. And we have facial nerve is there. That's the one which is again problematic area for the operating surgeon, that he should not damage the facial nerve as such. The recurrence rate, if you see, with the complete adequate parotidectomy, still around 4% of the cases may show recurrences. But with complete enucleation, around 25% are even known for recurrence. It's although benign, it's known for recurrence, that you have to remember. Even though with the complete enucleation also, sometimes somehow these pleomorphic adenomas are known for regrowth and even recurrence. So this is how I have told here by diagrammatical representation. You have to completely excise as much as possible. Classical case of pleomorphic adenoma is here. This is normal appearing salivary gland lobules. You can make out here. Here is the tumor mass. So sometimes it is multiple foci like this. So here is one lesion, here is one more lesion. So this is how it appears myxoid. We use the word myxoid because of the chondroid component, that is mesenchymal component. Most of the tumors will have this peculiar cut section myxoid appearance, mucinous like appearance. So it's mainly because of the cartilage that is present in these cells. So have a look of one of the case, but other cases may vary in their appearance. So this is epithelial component. You see, this is epithelial component, and this is mesenchymal component. So this mesenchymal component may be usually the cartilage. Even it can show the muscle differentiation or neural differentiation. So anything that is mesenchymal, but most of the time it is the cartilaginous differentiation. Sometimes osteoid differentiation can be seen. And this is a ductal component composed of benign appearing ductal cells. See here, so these are all benign ductal epithelial component mixed with the even myoepithelial component. And this is mesenchymal component. So it's a good mixture of the epithelial and the mesenchymal component. So this is how we have to diagrammatically represent. This is ductal component, this is mesenchymal component, this is fibroblast component, osteoid component, myoepithelial component. This is a cartilage can be seen in the pleomorphic adenoma of the salivary gland. Yes, remember this most important chart. Pleomorphic adenoma of the salivary gland does not show any pleomorphism of the cells. It is the pleomorphic components, ductal and the stromal components. So better word would have been benign mixed tumor of the parotid gland. So that is again used simultaneously with the pleomorphic adenoma. So we have variety of other pleomorphic adenomas. For example, pleomorphic adenoma of the skin is known as chondroid seringoma. That point you have to remember. Rarely the pleomorphic adenoma can give rise to the malignancies. Then we use the word pleomorphic adenoma X carcinoma. So the ductal component can give rise to the adenocarcinoma, or rarely, very rarely, the mesenchymal component can give rise to the sarcomas. So these things can happen. So remember, the pleomorphic adenoma is benign but known for recurrences. So this is what I told. The carcinoma can develop in the pleomorphic adenoma. Then we use the word carcinoma X pleomorphic adenoma, or also as pleomorphic adenoma X carcinoma. Both are one and the same. So malignant mixed tumors, they constitute around 10% of the cases, and it is long-standing cases. Pleomorphic adenoma which are neglected for many years, they are the ones which are known for development of the adenocarcinoma. Sometimes even undifferentiated carcinoma can develop. If carcinoma develops, then mortality rate raises. So it can become 50% mortality in the 5 years. One of the interesting benign salivary gland tumor again is the WARTHIN'S tumor. Remember, it's benign. So whenever you issue the report, the surgeon will immediately ask, is it benign or malignant? Remember, it's a benign tumor. So the alternate name you need to remember, Papillary Cystadenoma Lymphomatosum. So why this name is given? Because of the microscopic appearance. I'll show the pictures. So it is virtually restricted to the parotid gland. Most of the WARTHIN'S tumor, almost 90% of the tumors, occurs only in the parotid gland. So WARTHIN'S tumor is very common at the 5th and 7th decade of life. See the smokers, somehow we don't know exactly why. Smokers have 8 times more common incidence of the WARTHIN'S tumor. So we have seen WARTHIN'S tumor, and if you ask the history, invariably there will be male smokers. So this is what we have seen, and it's true that smokers have highest incidence of the WARTHIN'S tumor. Around 10% of the cases are bilateral and multifocal, but most of the time they are unilateral. Probably it is occurs from aberrant salivary gland rest in the lymph nodes. Probably that is the reason why WARTHIN'S tumor will arise. So The histological name, what is the histological name? Papillary cystadenoma lymphomatosum. So papillary projections are there. Cystadenoma because there is a cystic spaces are there. Lymphomatosum because there is a dense lymphoid aggregates. So that makes the perfect name, histological name for the WARTHIN'S tumor. Peculiarly, this epithelial lining shows dual population of cells. The one is the oncocytic long columnar cells and one is the basal appearing leukoplakial cells. So this is how it appears under higher magnification. And there is dense lymphoid infiltrate. So lymphocytes and plasma cells will be there. Rarely this WARTHIN'S tumor, this lymphoid population can give rise to non-Hodgkin's lymphoma. That point you have to remember. WARTHIN'S tumor rarely can even give rise to the non-Hodgkin's lymphomas. Diagrammatical representation of the same here. So dual population of cells, oncocytic cells and basal leukoplakial epithelial cells, and dense lymphoid aggregates, lymphocyte and plasma cell accumulation, and the cystic spaces containing the mucoid material. So this is WARTHIN'S tumor. One of the interesting malignant tumor is the adenoid cystic carcinomas. It is very common in the minor salivary glands. So it can also occur over the nose, in the paranasal sinuses, in the upper respiratory tract. It is slow growing tumor and the prognosis is totally unpredictable. What's the peculiarity of the adenoid cystic is it invades the perineural spaces. So perineural invasion, we use the word perineural invasion is the mode of spread of the adenoid cystic carcinoma. So whenever we see the adenoid cystic carcinoma cases, we will take multiple sections again to demonstrate the perineural invasion. So that's the way how the tumor spreads. We have told about various routes of spread of a tumor, but perineural spread is very peculiar for the adenoid cystic carcinoma. So it is very much known for its recurrences, and it also can metastasize to the bones, liver and brain. Prognosis, like what treatment, 5-year survival is around 60 to 70%, 10-year survival is the 30%. One of the important again tumor I have not told here is the mucoepidermoid carcinoma. So it shows the combination of both the mucinous component as well as the mucoid secreting glands will be there, as well as the epithelial component will be there. So mucoepidermoid carcinomas, you will see mixture of adenocarcinomas and even squamous cell carcinomas. So mucoepidermoid carcinomas, again very commonly they are seen in the minor salivary gland. So whenever we see minor salivary gland tumor, most of the time they are malignant. Rarely we can come across the mucoepidermoid carcinomas in the salivary gland as such. Let us see the few lesions of the esophagus. Esophagus, very common entity what most of the population will suffer is the reflux esophagitis, where gastric and contents will reflux back into the esophagus. It could be due to the inefficient anti-reflux mechanisms. The lower esophageal sphincter can become inefficient. So variety of causes can be there, underlying causes. CNS depressants can cause this inefficiency of the anti-reflux mechanism. Pregnancy, when uterus becomes enlarges in size, late pregnancy can cause systemic sclerosing disorders. Alcoholism, tobacco, nasogastric tube for a long time, that can also cause reflux esophagitis. And the sliding hiatal hernias, inadequate clearance of the reflux material, and delayed gastric emptying. So these are the few causes of the reflux esophagitis. Carcinoma of the esophagus, most important etiological factor is the genetic predisposition, which is not yet clear. Probably it's the lifestyle factors. They are important for the squamous cell carcinoma of the esophagus and even adenocarcinoma of the esophagus. Most important is the spirit, that is alcohol consumption, tobacco use, especially smoking, and urban environment. So they are the important etiological factor for squamous cell carcinoma of the esophagus. Pre-existing lesions can also give rise to the esophageal carcinomas like long-standing esophagitis, achalasia cardia, Plummer-Vinson syndrome, that is post-cricoid crab. Dietary deficiencies like vitamin A, vitamin C, they are the one which again can predispose for squamous cell carcinomas. Fungal contamination of the food like aspergillus. So aspergillus is the one which can cause the carcinomas, and even nitrates can also cause the esophageal carcinomas. Betel nut chewing is also important cause. So they will ask us question, which portion of the esophagus most is known for carcinomas very commonly. If they classically ask that squamous cell carcinoma, it is the middle portion. The middle portion of the esophagus is very commonly suffer from squamous cell carcinoma. Whereas if they ask adenocarcinoma, is the lower end of the esophagus. But overall, in some of the surgical books, it has been mentioned that mid esophagus is the most common set of the esophageal carcinomas, especially it is the squamous cell carcinomas. and they are polypoidal in 60% of the cases. They can be flat, they can be excavating. So this is grossly how they appear. Initially they start as in situ carcinomas, but later on they can become invasive carcinomas. Patient will have an insidious onset. Dysphagia is the most important clinical sign and symptom. So gradually it will obstruct the food passage. Patient will have a severe weight loss and even debility. Hemorrhage can occur if there is a mucosal erosion. Sepsis can occur, and it can even lead to the tracheoesophageal fistula. It is very much known for its spread to the adjacent group of lymph nodes. But survival is not so good. If it is very superficial, okay, 75% of the cases will survive with the treatment. But if it is advanced case, most of the time they will present with advanced case. So local and distant spread is very, very common. So advanced stage will not have good survival rate. So they were having very bad prognosis. So this is how the squamous cell carcinoma that is infiltrating into the underlying muscle layer. So this is a tumor mass. It is showing infiltration into the underlying muscle mass. This is how it appears under microscope. So diagrammatically you can represent individual cells are showing keratinization, polygonal cells showing all the features of anaplasia. So desmoplastic reaction is there, keratin pearl formation is there, dense immune response is there. So this is squamous cell carcinoma of the esophagus. Rarely Barrett's esophagus can give rise to the adenocarcinomas. So remember, Barrett's esophagus is metaplasia. The squamous epithelium is replaced by gastric type of epithelium. That can give rise to the adenocarcinoma of the esophagus. Or it can be also due to the point mutations in the P53 genes and even with the functional inactivation of the P53. So most common site is the lower end of esophagus where survival rate is very, very less, very, very less. So this is how the adenocarcinoma, classical adenocarcinomas will appear. So they show glandular formation and infiltration into the underlying structure. So glands infiltrating into the underlying muscle. So remember, this is how the neoplasia as such they will develop. Normal will become hyperplasia, further metaplasia, more dysplasia, mild, moderate, severe dysplasia. Then it results in the infiltrative tumor, which is known for the metastasis. As you know in the chapter of neoplasia, accumulation of the mutations is the basic rule for the onset of tumors. So more and more DNA mutations will accumulate and they lead to the development of the malignancies. Thank you.